Wow, what a pleasure to follow on from Mercedes' fantastic presentation, which relates and overlaps so much to my work as well. As you'll have noticed, I have no PowerPoint. The reason for that is because, well, partly because we've all had death by PowerPoint, I think, over the last 18 months, and you really don't need another one from me. And the other reason really being I'm not an academic. This is not a lecture, there are no learning outcomes. So I know it's morning time in America where most of you are. You can relax, have your coffee, and we're just going to have a casual chat, okay? So yeah, as introduced, my name's Leah Hazard. I am a midwife here in Glasgow, Scotland, in the UK, although I was born and raised in America, hence the funny accent. I have been registered as a midwife since 2013. And in that time, I've worked in our National Health Service in every clinical area that you can imagine. So from antenatal clinics to labour wards, postnatal wards, home visits. In the NHS, we really cover every aspect of care during the childbearing year. In the last few years, I've also been lucky enough to do some writing about my work. I've published a book called Hard Pushed: A Midwife Story, which I'll tell you about in a minute. And I'm really excited to be working on my next book at the minute, which is called Womb, the Inside Story of Where We All Began, and that will be coming to you all over the world in 2023. So enough about me. I will go on to talk a little bit about the midwife's role specifically here in the UK, which has a lot in common with the role of midwives in America and elsewhere, but also has its own sort of statutory and regulatory unique aspects here in the UK. So in the United Kingdom, the governing body or the regulatory body for nurses and midwives, two different roles, is the Nursing and Midwifery Council. And currently there are just over 42,000 midwives who are registered with the NMC. And the NMC defines the midwife's role in this country as such. It says the midwife's role is to provide skilled, knowledgeable, respectful and compassionate care for all women, and I should add all birthing people, newborn infants and their families. They work across the continuum from pre-pregnancy, pregnancy, labour and birth, postpartum, and the early weeks of newborn infant's life. So far, probably so similar to what you're used to in the US and elsewhere. But I'll tell you a little bit more about how we train and how we do indeed qualify as registered midwives. So in the UK, there is just the one route to midwifery. We don't have the distinction between sort of CPMs and CNMs and lay midwives. To become a state registered midwife, you have to undergo a full-time university degree. So that can be 3 to 4 years, depending on whether you choose to enroll in an honours or a master's degree level course. And during that time, our training consists of roughly 50% classroom time and 50% clinical placement. And again, that could be in any of the clinical areas that I've just described earlier on in my talk. This covers a multitude of competencies and skills. One of the things which hasn't really changed in midwifery qualification here for years is that student midwives have to participate in the delivery of 40 vaginally born babies during their training. And we also have other sort of related and adjacent rotations in things like gynecology clinics, day surgeries, and related fields. When we do finally qualify, we're able to do a few things that most nurses in this country can't do, and I think some things that are a little bit different from the skills accredited to certain midwives in America as well. Okay, so we can do minor surgery, by which I mean episiotomies. We can also suture, we do perineal repair. We can prescribe. In the UK, we have a midwives formulary, and we can prescribe a multitude of medications from antiemetics to painkillers, opiates at times, and a number of other medications. We can be sort of scrub assistants for cesarean sections and forceps deliveries. And we also are able to care for the critically ill birthing person, which has, as you can imagine, come in very handy over the last 18 months with COVID. And during the pandemic, our role has really expanded and become even more challenging, if such a thing were possible, because we have had to care, unfortunately, for so many pregnant women who have been ill with COVID. So it's really important that we can identify the deteriorating woman and manage her care accordingly. Now, in my particular case, although I have rotated through all the clinical areas of the NHS, I have worked for the most part of the last 5 or 6 years in maternity triage, which I describe as like A&E for pregnant people, or like the ER for pregnant people. Okay, so we deal with every kind of urgent and emergency issue that a woman might encounter from the very earliest weeks of pregnancy up until about 6 weeks postnatal. So that can include everything from reduced movement, nausea and vomiting in early pregnancy, bleeding, hemorrhage, sepsis, waters breaking, normal labor, more complicated labor, obstetric emergencies such as cord prolapse, and postnatally things like wound infections, mastitis, perinatal mental health issues. We also are really proud to serve as a safe place for women who are experiencing emotional difficulties and or gender-based violence. So we really do see everything, and we are at the sharp end of the system. Now, I'll talk a little bit about why I wrote my book, Hard Pushed. I wrote it in 2018 and it was published here in the UK in 2019. It is available in America. I think you can order it. And the reason I wrote the book is really because my colleagues and I were working so hard, and I was always overwhelmed by the complexity and multifaceted nature of our role. And yet, at the same time, I felt that there wasn't really any accurate representation in the public realm of what the modern role of midwifery really is. Okay, so I think a lot of people still think of the old-fashioned call the midwife style, midwife on the bike, going out catching babies, smiling all the time, very cuddly, very cozy. And oftentimes when I tell people I'm a midwife, they say, oh, that's great, you must love babies. And yes, I love babies, but babies are actually only a very, very small part of the contemporary midwife's role. So I felt that there was a real lack of understanding in the public eye of the role. And also at the same time, unfortunately, a lack of appreciation for the complexity of the role and its demands. And that, in this country at the very least, is reflected in severe underfunding, understaffing, and a general lack of resources. So I was hoping to raise awareness in a way of the complexity of the role and also the breadth of the role and what it is that we really do. So if you'll humor me and bear with me a minute and get comfy with your coffee, and I'm just going to read a short passage from the book, which really is all about the fact that most people really don't realize what it is that midwives do until they're actually involved and engaged with the system. So in the particular passage that I'm about to read, I'm talking about a day when I had assessed a woman in triage and she was in active established labour. Because the hospital was short-staffed, as it so often is, I was asked then to go with the woman to the labour ward, to stay with her there, to do her intrapartum care, which I did. She had a lovely birth, and then I assessed her perineum, sutured it, and was busy tidying up afterwards when I had a chat with baby's father about what had just happened. So I'll read that for you now. I busied myself tidying the usual mess while they settled into their first breastfeed. As I worked my way across the room, stuffing bloodied drapes into bin bags, tossing absorbent pads onto puddles of bloody liquor, and collecting instruments that had been flung to the floor in the final moments of delivery, I became aware that Stephen was watching me from his seat at Michelle's bedside. At first, I pretended not to notice, but as his eyes followed me around the room, when our gazes met. Sorry for staring, he said. I just can't believe everything that you've done for us today. You met us in triage, and then you came here and looked after Michelle all afternoon, and then you delivered our baby. Then you scrubbed up and did Michelle's stitches, and now you're cleaning. I keep thinking, where's the cavalry? I guess I thought there would be lots of other people in the room, but it's just you. You're the cavalry. Yep, I said as I lifted a bale of bloody sheets from the floor. I'm it. I tell this story not to illustrate my own brilliance. Any midwife would have done the same for Michelle, and many would have done it with even greater skill. Rather, the point is Stephen's revelation that midwives do so much more than catch babies. We devise and implement plans of care. We connect, console, sympathize, and cheerlead. We prescribe. We do minor surgery. You see us all the way through your pregnancy, and we visit you afterwards in your home, making sure that you and your baby are well, and reminding you that cooking and cleaning and pretty much everything else can wait. When labour goes well, we're the only ones you'll see in the birthing room, And when it doesn't, we scrub for you in theatre and then bed bath your broken body in recovery. We believe you when you say you don't feel safe at home, and we hold you in our care until shelter is secured. We may never have met you until the day we ride into battle for you and your baby. And like Stephen, you may not even recognize the cavalry that's been at your back until the drapes are down and the blood has dried beneath your feet. And yet, every day, in big city hospitals and small rural birth centres, in clinics and wards, midwives of every age and stage are evaporating like so many puffs of smoke. For too many of us, the pressure and exhaustion have become too much to bear. But thankfully, for every midwife who's left, thousands more of the cavalry remain, kneeling by bedsides, answering phones, running for buzzers, telling you it's fine, you can do it, you are doing it, keep pushing. And you push and push again, and so do we. Now, again, I read that passage not because I'm a great midwife or that I did anything special, but because this is what midwives do all day, every day, especially in this country, where we really are the main providers for women's care all the way through the pregnancy and puerperium. And we are generally quite autonomous practitioners as well. Unfortunately, as I alluded to at the end of that passage, so many midwives are leaving or are keen to leave because of burnout, stress, and exhaustion. And this really was the case even pre-COVID and at the time that I wrote the book. Now, the sort of biggest, most recent study of midwives' mental health and personal experience is something called the WHELM study, WHELM as in overwhelm, in 2017 by Hunter et al. And this was a survey which had 1,997 midwives as respondents. And the results of that survey actually are pretty staggering. In short, the midwives are not okay. 83% scored moderate or above for personal burnout. 67% scored moderate or above for work-related burnout. And more than a third of respondents scored moderate, extreme, or severe for stress, anxiety, and depression. And again, I must stress, this was pre-COVID, when everything was so-called normal. Now, we know how much of a strain the pandemic has put on the health services all around the world over the last roughly 18 months. And you can't even open a paper these days without hearing, and rightly so, about the stress this has placed on doctors and nurses. Unfortunately, midwives seem to kind of fly under that radar for whatever reason. I think we're still kind of perceived as smiling and uncomplaining, and it's just accepted that we will just get on with our job, even with the added layer of COVID stress, without really kicking up a fuss. Obviously, that's not true. We're human like everybody else. We still have a really complex role. In fact, in most clinical scenarios, we have not one, but two patients in our hands at any time. The lives of those two patients are constantly hanging in the balance, mother and child. So you can imagine how things have changed since I even wrote that book and since the WHELM study was carried out. There is some data recently to indicate how midwives have fared during the pandemic. So this year in this country, there was a YouGov poll that found that 29% of nurses and midwives were more likely to leave the profession than a year ago. There was also a really recent study, I think by Pizarro et al., which found that midwives are much more likely than any other health professionals to have substance abuse problems. Whether that says anything about the midwives or the profession itself is up for debate. But what's very clear is that our profession is really struggling. And I'm sure that that is the case in midwifery spheres all around the world, regardless of their statutory status or professional qualifications. Now, why does this matter? Why do midwives matter? Well, I can go on and on about how special I think our role is, but my opinion doesn't really matter. We'll turn to some hard facts and some data. So time and time again, research has shown that midwifery care actually saves lives, that midwifery care can decrease stillbirths and improve maternal and fetal health outcomes, can reduce morbidity and mortality. If our well-being really comes secondary, then at least we can be sure that the well-being of the patients in our care only benefits when midwives are involved. Now, why our profession has been sidelined, I'm really not sure. I think probably we can blame the patriarchy to a certain extent, and the fact that unfortunately the purse strings are generally controlled by a patriarchal model within government. I think midwifery historically and in the future has and will always be somewhat under-resourced and underfunded, because it is predominantly a system that is run by women for women. And unfortunately, the needs of that population may be, at many times in our life, as Mercedes said, greater than the male part of the population, but less recognized and less resourced. Hopefully things will change, but I think for the moment, we're still in the thick of it, and there isn't much improvement on the horizon. So I'm more than happy to take any questions. I'm just going to have a look at the Q&A. There's nothing at the moment, but if you do have any questions about midwifery in the UK or any comments for the future, that would be absolutely fine. I'll just give a moment if anybody wants to fire through any questions at all.
I have a couple of questions, Leah, while the QA sort itself out. The first one has to do with episiotomy. When I gave birth to my child 1700 years ago, episiotomy was everywhere. Everyone got an episiotomy, no questions asked. Is this still the practice? Because I think that it's, okay, just tell me what's going on with episiotomy and what is your opinion?
Yeah, I'm happy to say it's no longer still the practice. I think it used to be thought that routine episiotomy was better for women than sustaining a tear that would need to be sutured and maybe would heal less perfectly or less completely than a nice, neat, straight episiotomy. But I think, again, within that attitude is an underlying sort of patriarchal assumption that women's bodies aren't enough, and that the things that women's bodies do physiologically during birth are inherently dangerous and inferior to what science can do to women's bodies or what medicine can do to women's bodies. And there was never really any data to support the use of routine episiotomy. So while it's true that some spontaneously occurring tears can certainly be catastrophic, and there can be subsequent complications, we know now that for most women, any spontaneously occurring tears that are then sutured and managed appropriately will be safer, better healed, and more comfortable in the long term. So I'm happy to say that routine episiotomy, along with routine enemas and pubic shaving and things like that, has gone the way of the past.
How about the birth position? It's sort of counterintuitive that, to push a baby out, you're lying upside down with your legs up in the air. In Israel, we have large populations that go to the hospital to be near a hospital when they give birth, and then they squat on the ground holding a pole and give birth to a child with no assistance. So I was wondering if there's any change in opinion about this, or if you have any opinion.
I mean, I think what you're referring to is this lithotomy position where the woman is on her back with her legs up, usually in stirrups. And this position is one that we know is very seldom adopted by women when they're left to just birth themselves undisturbed physiologically. Now, there are a number of factors why most women in hospitals will still birth in this lithotomy position. Probably a lot has to do with the design of the rooms themselves. There's just a big bed with stirrups in the middle, and many hospital units don't really encourage or facilitate other sort of birthing furniture or ergonomic environments that would promote different positions. Another factor is probably widespread use of epidural, which is not to be shamed and disapproved of, but certainly immobilizes women and means they can't really adopt more gravity efficient positions. And a lot of it is probably to do with the fact that the sort of obstetrically dominated birth environment in many cases is sort of has evolved more to suit the practitioner, the obstetrician, rather than the woman herself. And the very word obstetrician means a person who stands in front of. Obstetrics is standing in front of, basically. And that name and that field really only came about when obstetricians sort of usurped the role of female midwives in the sort of 17th and 18th centuries. Having an obstetrician at your birth became something that was a marker of status, and that was much to be desired as a luxury and a marker of your wealth. And if you are a wealthy woman, you would be on your back with your big skirts and dresses on, and your obstetrician would literally stand in front of you, put his hands under your skirt, and deliver your baby. So unfortunately, although we've come a long way since then, in many ways we also haven't. And that's a long answer to your simple question about positions in birth. I'm just going to have a quick look at these questions now.
There's 3 questions in
Yes.
the Q&A, so perhaps you can address them.
Yes. Hi. So excellent talk. There is 3. We'll try and see if we can do all 3. So the first question is from Marcia. What is the UK training for midwives? Would you describe your role? How would you describe your role in the case of a COVID case, a pregnant lady with a COVID case? So you can comment.
Yeah, so I've spoken a little bit about our training in the sense that it's a full-time university degree, which is part clinical and part academic. I think I'll focus more on the second half of the question, if that's okay, which is, would you describe your role in a COVID case of a pregnant woman? So it's a tricky one. As midwives, again, we are the lead caregivers in pregnancy and birth, and we always aim to provide holistic woman-centered care to support and advocate for the woman. But at the same time, if she comes in and she's critically ill with COVID, we have to switch our medical brains on, and we have to be sort of ITU nurses as well. And we have to identify any signs of clinical deterioration. We have to keep an eye on fetal well-being. We have to escalate and work with a multidisciplinary team, by which I mean obstetricians, anaesthetists, other medics who might be involved in that woman's care. And we have to do it all in head-to-toe PPE. So we try and preserve the nature of our role and the skills that we bring to it, but it's also very challenging because we have these additional demands. I'm going to move on to the next question, if that's okay, because I'll try and get this in before I finish.
Great.
So Heather says, what do you say is the comparison of pregnancy-related deaths between midwives versus obstetricians? Well, I think we need another half hour at least to unpick that question. In a way, it's a sort of unanswerable question because the very caseloads of midwives are somewhat different from patients who will need obstetrically led care. So by virtue of their job, the obstetricians will tend to be involved in the care of women who have more complex medical and obstetric demands. So I would imagine that their mortality rates would be a little bit higher. It's a tricky one though, and we could certainly unpick that. I wouldn't want to say that one is safer than the other because we're a team and we work very closely together, but I think the obstetricians would tend to be more frequently involved by virtue of their role in the care of women who have some other complication. Final question, Diana Nielsen says, my 2 daughters were expertly cared for by midwives, glad to hear it, who safely and compassionately delivered my healthy 4 grandchildren in birthing pools. And she says, thank you. And that's wonderful. So thank you very much, and you're welcome on behalf of all midwives.
Okay, that's great. Okay.
We have a couple of minutes left, so I wanted to ask you, it's a little related to the obstetrician versus midwife question by mortality. How about home birth, where midwives assist versus hospital births? What is the experience there?
Would you mean like the experience in terms of what it's like for women, or how that works?
Women and the babies, the outcome of the pregnancy, yeah.
Yeah, well, there's lots of data regarding home birth versus hospital. Generally, the consensus is that for women who are healthy, fit and well during their pregnancy, the outcomes for women and their babies are very similar, if not in some cases better than hospital-based births. And we have to remember that, yes, although there are risks inherent in giving birth in a home-based setting, there are also risks inherent in going into an obstetrically led hospital-based setting. It does always have to be an individual decision, and I would encourage women to make that decision in conjunction with caregivers that they trust, who have knowledge of their personal medical and social history. Having had one hospital birth and one home birth myself, I know how I feel about it. My home birth was a fantastic experience, the hospital birth less so. But it is also possible to have a really safe, uplifting and joyous experience in hospital. And I've certainly seen that happen many, many times.
Thank you.